Good morning, everybody. You all are welcome to the KSM Wednesday lecture series. Today, the lecture is more relevant for the males, so there's a lot of male gatherings are here. So today, the speaker, I think he doesn't need any introduction. And when I asked for the CV, he said not to do all the credentials, but he's a consultant GU surgeon in National Hospital Kandy, and my personal note, he's a hardworking surgeon. He's Dr. Kanchana Edirisinghe, and he's going to talk about the benign prostatic hyperplasia. Over to you, Dr. Kanchana.
Thank you very much for the kind introduction. So I'm going to talk to you about benign prostatic hyperplasia. Though we are talking about benign prostatic hyperplasia, we'll be talking about the low urinary symptoms, and it is one of the cause for low urinary symptoms only. So BPH is a histological diagnosis. So that means though we consider it is due to the benign prostatic hyperplasia, unless we do a sampling of the patient, we can't say this as the diagnosis. This is the pathology behind that, defined as the increase in the total number of stromal and glandular epithelial cells within the transition zone of the prostate gland. So what happens when this occurs is the benign prostate hyperplasia, it causes an obstruction to the urine flow. And this is a clinical diagnosis at the end of the day. So the prevalence of BPH increases with the age, and when you are around 60, there will be 50 to 60% chance of you having these symptoms, and it goes on like this, and 80% when you are over 70 years of age. So there are risk factors for BPH. Some are modifiable and some are unmodifiable. So these are the race, genetic susceptibility. So it runs in families, and they say American and African Hispanic nations are more prone to the disease. And when you have high testosterone levels, this can be a cause. And modifiable risk factors is metabolic disease like diabetes mellitus increase chances of you having this prostatic symptoms due to benign prostatic hyperplasia. And if you are a PC drinker, then there's high chance. Alcohol consumption and increased fat intake, and when having a cardiovascular risk factors like ischemic heart disease, because of the obesity and diabetes mellitus, you are prone to get this disease. And the symptoms can be associated with neurological factors, neurological diseases as well. So what happens when you have this problem? This is the pathophysiology behind this. What happens is there's obstruction to the urine flow, then the bladder starts hypertrophy, and at some stage it will be atonic, and you can develop diverticules, sacules, and trabeculation in your bladder. And towards the end of the picture, there will be a retrograde proportion of urine, and you can have hydronephrosis, and at the end of the day, kidney damage. So we can see a full range of disease or pathophysiology in most of the patients. Some comes with only the thickened bladder wall, some with trabeculation, some with diverticulum, some with atonic or large bladders with large residual urine, some with bilateral hydronephrosis and hydrouresia. So this happens if you are not treating this disease. So what we assess is low urinary symptoms. It can occur due to various array of diseases, including overactive bladder, distal ureteric stones, bladder tumors, neurogenic bladder dysfunctions, and we will be assessing all these diseases, or otherwise we will be excluding all these diseases and come to a diagnosis of BPH due to lower renal symptoms due to BPH. That's why I said it is a clinical diagnosis. So how do you assess these symptoms in our patients is using this International Prostatic Symptoms Score. It contains 8 parameters, including the quality of life, which are relevant to the famously known as voiding and storage symptoms of lower urinary symptoms. What are voiding symptoms? They are slow urinary stream, straining up to void, urinary intermittency or hesitancy, splitting of voiding stream or intermittency, we call it, or terminal dribbling. What are storage symptoms? Urinary frequency, urgency, and nocturia and incontinence. So they can present you with a asymptom. That means they can have benign hyperplasia of the prostate, but still they can be asymptomatic. They can come with mild symptoms, moderate symptoms, or severe symptoms. So does the size of the prostate matters with these symptoms? There are studies saying that it matters, but even with a very small prostates, patients can have full range of symptoms with this disease. And there is another parameter we take into account is the intravesical protrusion of prostate. That is from the base of the bladder, how much of your prostate is protruding into the bladder. When there is a growth of the median lobe, it can act as a wall valve and cause more and more symptoms. So this comes from the work done in Singapore, and now it is included in most of the guidelines as well. So we consider this also when we start treating these patients and when we are taking them into surgical management. So this is the paper produced by Singapore. The main man behind this is Dr. K.T. Poo. He is considered as the father of urology in Singapore. So what are the complications you can have due to this disease? So patient can present you with acute urinary retention. Some come with a chronic urinary retention. Some comes with the recurrent urinary tract infections. Some comes with the incidental diagnosis of bladder stones. And some are coming with the complications of bladder diverticula, and very unfortunate ones will come to you with the renal damage, or will be diagnosed in this disease when they have a deteriorated renal functions. So how are we going to assess these patients? The important thing is clinical evaluation. We should take a good history and examination and find out what is wrong with them. And we can put them into IPSS score and assess their symptom severity, whether they are in mild symptom group or moderate symptom group or severe symptom group. We should do a urine analysis just to exclude hematuria or whether they are having an infection. So when they come with a late problem, we should assess their renal functions as well. The most important imaging in study we can do is the ultrasound examination, which will tell you whether patient's size of the prostate and whether he has got large residual urine, whether he has got bilateral hydronephrosis or any other complicated things like bladder stones. So depending on the finding of ultrasound examination, the management differs. The uroflowmetry is a simple urodynamic, which will help us to diagnose whether he has what sort of obstruction he has got due to the benign prostate hyperplasia. The usual urine flow rate would be around 25 milliliters per second, but when you have a prostatic problem, it can go down up to 3 or milliliters per second. So you will be living in the toilet more time than you used to do in your young age. And sometimes, if there is suspicion, we need to do serum PSA assay too. But we should choose our patient and do this investigation. Otherwise, we will be treating unnecessary, or we will be sending a patient through unnecessary array of investigations like trust biopsies, MRIs, and things like that, just because we have done the PSA in the wrong time. So we have to be very careful to do the PSA when we are dealing with these patients, because I have seen most of them do PSA when they come to you with acute urinary retention. It is a causative factor for increased PSA, or after the intervention or after the infection, right? Because of that, we should be very careful in doing this. So other things help us to diagnose when the treatments are failure, like bladder diaries. When they are not improving, we can use that. Cystoscopy, if we suspicious of any other thing other than the BPH, and advanced urodynamics studies when we are failing in surgical procedure or the patient is very young, we can't explain the symptoms. So we should refer, because this is a diagnosis by doing or excluding a lot of other diseases when the patient has got severe symptoms when they are very young, and if you think that digital rectalization is unusual, or whether they are present with hematuria or microscopic hematuria, or if you happen to do a PSA when it is high, and although we are treating for this disease for a long time, they are still having dysuria, we should exclude a malignancy inside the bladder. So this patient should be referred to us through further evaluation and management. So what are the treatment options we have got? We can do watchful waiting and lifestyle changes which will help the patient, and herbal therapy, which I'm not very fond of, but no idea also. But in Chinese herbal medicine and a lot of local remedies are used for these patients, but without much scientific evidence. And we have drugs to treat them. We have monotherapy, we have combined therapy, and as the last resort, we have got surgical management, which may be a major surgical undertaking or a minimal surgical undertaking, depending on the patient's condition. So, who are the ones suitable for watchful waiting? For men with mild to moderate symptoms, minimally bothered some symptoms, and we can offer watchful waiting. And we should follow them up, and at the end of the 5 years, only 21% goes into the treatment arm. And with that, we should be educating them, we should be treating them with a lifestyle modification, which will help to keep them in the watchful waiting arm for a longer time. So these are the recommendations given by EUA for watchful waiting. So for men with mild to moderate or minimally bothered by their symptoms, watchful waiting can be offered. It is a strong recommendation. So what are the behavioral intervention we can do? We can educate the patient about their condition, and we can teach them what to expect from or how they can find out whether symptoms are worsening. And we can reassure patient, because most of them will come to you with a fear of malignancy harboring inside body, because this is prostate cancer is a well-spoken topic all over the world. And we can monitor them periodically, maybe yearly, maybe half an yearly, and we can give them the lifestyle advices to them. So what are the lifestyle advices we can give? Avoiding fluids towards the evening, because when you have nocturia, we should avoid the fluids towards the evening. If you are taking a furosemide in the night for their heart disease, then we can ask them to take it around afternoon, and then it will reduce the urine production in the night. And ask them to double void if they are feeling that they are having an incomplete emptying, or if they are having a significant amount of residual urine. So, and we can ask them to, or teach them how to do, or how to prevent dribbling with at the end of the urination. So we can teach them distractant techniques to avoid go to the toilet when they feel that they need urgency to go there. So these lifestyle advices can go hand in hand with the treatment or with them alone. So what are the pharmacological treatment we have got? So we got monotherapy, we got combination therapy, and they act differently in different places. So there are things that act in prostate as well as in the bladder. There are things that act on the prostate itself. Likewise, we got several groups of pharmacological drugs. So who are the patients we are going to start on treatment? So if they have got moderate symptoms, if they have got complication of this phenomena, then we can start treatment. So what are the treatment strategies we got? In pharmacological aspect, we got alpha-1 adrenergic antagonists, we got 5-alpha reductase inhibitors, we got anticholinergic agents which can be combined with this treatment, or newly we can do phosphodiesterase inhibitors, which will act on prostate, bladder, as well as the most of the areas, but the way they act is not proven yet. So if they have moderate symptoms, we can start monotherapy. If they are very young, then we can start monotherapy. If they don't have very sexual concerns, then we can start monotherapy with alpha blockers. But elderly with moderate symptoms or severe symptoms, we can start using combination therapy with them, which may be 5-alpha reductase inhibitor, or if they have sexual concerns, 5 LUTS inhibitors we can add to the these medications. So for patients with severe bothersome symptoms, IPS or 20 or WITO, who do not have adequate response to maximal monotherapy, with an alpha antagonist, we can alpha adrenergic agonist, we can add 5-alpha reductase inhibitors. For men with post-vital residual urine volumes and irritative symptoms that persist during the treatment with an alpha adrenergic agonist, with combination treatment with an anticholinergic can be added. That means if still we treat them, still they got a larger frequency with low residual urine, then we can add an anticholinergic agent. So for men with moderate symptoms and erectile dysfunction treatment with daily, we can start tadalafil or some that 5-alpha. Sorry, it doesn't come. So which drug is used for a sexual stimulation. So this is some facts about these alpha adrenergic antagonists. So they reduce the tone of the smooth muscle and muscle of the prostate and the bladder neck. They act on alpha-1 receptors, and they tend to act quickly. That means within 72 hours we can have the benefit of the drug, or the results from the, or we can hear the results from the patients. These are the example of these drugs: prostacyclin, which is very non-specific, teracyclin, alpha-cyclin, tamsulosin, and silodacin. So it will not affect the PSA level. So 5-alpha reductase inhibitors inhibit the conversion of testosterone to diesterone, decrease the size of prostate in time to come. That means they can reduce up to 30% of the prostate size. Onset of action is slower. They might take 3 months to act on the patients. So what we have is dutasteride and finasteride. So these are the most commonly used 5-alpha reductase inhibitors. So now, after choosing them, we will be moving on to the surgical management. So what are the indications for surgical management of this disease? So when they have, while they are on treatment, when they are getting recurrent attacks of urinary tract infections or recurrent attacks of urinary retentions, when their hematuria cannot become controlled with the 5-alpha reductase inhibitors, and when they are getting bladder stones or complications of this disease, or whether when they have got bilateral hydronephrosis, we call that disease as a high pressure chronic retention, they need a surgical management of this disease. So the procedures of this surgical procedure depend on the size and the shape of the prostate gland, and whether the patient has got a bleeding risk, because lasers with minimal bleeding can be used when the patient has got a high bleeding risk. So if the patient has got stones in his kidney bladder, then we need to do combined procedure like removal of the stones as well as the prosthetic treatment. And if they are worried about retrograde ejaculation, which is a complication of the surgical procedure, then we can try and do bladder neck preservation, which may be successful. Or we can go for other things like prostate urethral lift and things that which are meant for a comorbid disease. And the available facilities and the surgeon's experience. So though we talk about a long array of procedures for a BPH, in our country we do have only few of them, like TURP, TURIS, and maybe laser in the Colombo suburbs. So again, as I said, when it is small, we will be using around 30 milliliters. We will be using TURPs. So when they are big, as 30 to 80 milliliters, we will be using TURP, laser enucleation, bipolar enucleation, and things like that. So there's a place, if they are very big, there's a place for open surgery or stage procedures, like we can do one side and come back and do the other side. And if they are not fit for surgical procedure, we have left it prostate lift. That means we can lift the prostate lobes and allow a good channel through the prostate. So again, the same thing. These are called ablative therapies. I'm not going to go into detail of these things. These are surgical procedures for benign prostate hyperplasia. Okay, I'm going to stop there because these are the basic things that we consider when we come across with a patient with low urinary symptoms, which occurs due to the benign prostate hyperplasia. If there are any questions, I would like to answer them. So what they say is even sexual activity can increase it for 48 hours. Right? Instrumentation of the bladder. That means if they had a cystoscopy, recently we should avoid that. Other thing is infections in the urinary tract, which can elevate the PSA for a long time. So we should wait until at least 6 weeks. And transurethral or any other procedure in the prostate, and even the bigger glands got increased PSA levels. So when they are, and the patients who have gone into acute retention of urine due to any reason, then the PSA levels can go up. So we should not do it when they come to you in the emergency department. We should not send a PSA unless it is indicated. Or if we happen to find an abnormal DRA suspicious of malignancy, then there's a place to send a PSA when they come with the acute urinary retention, but not otherwise.
Okay. How long you have to wait for PSA?
DRA itself will not increase, but if you can wait at least a day, should be beneficial. But it is not mentioned in the. No, not necessarily. It is also increase your PSA levels, because there is what happens when you have a retention, and then retention itself has the catheterization. So in our part of the world, the prostate malignancy is not very common. So we shouldn't be doing, or we shouldn't be screening all the patients who comes with LUTS with PSA, because we need to choose them, counsel them, and then we need to explain them the next array of investigations like MRI, thrust biopsies, and at the end of the day, we'll be doing a radical prostatectomy. So we need to inform them and then do them, and we should consider the life expectancy of the patient as well before we do that, because it is a long array of investigations after the high PSA. Yeah, so all the things taken out from the urinary tract will be sent into the. Not very common, I would say. Maybe 1-2%. No. So all, as I said, it is a clinical diagnosis. So when they have complications like high residual urine, bladder stones, TURP is the or surgical intervention is the treatment. But if the patient is satisfied, is happy to get up in once in the night and with no complaints, and if his symptoms are improving, we can continue the treatment. Otherwise, we should change the treatment now. Difficult to say, because this kind of if a BEPH patients comes to you with a increased frequency for 3-4 days, then we should again the lot of diagnosis behind that. He can have a stone, he can have an infection, you can have bladder cancer. So it is not very, though it is not very common, so we can't say. So if we suspect that, that means if he has got a family history, when we do a TRE, we can feel a nodule, then we should say, because since it is not very common.
Thank you very much, Dr. Khan. I have a question. So in Sri Lanka, the BPH, what is the mean age group you have in the first income in Sri Lanka study?
As I said, so what we say is around 50, you can get these symptoms. So we all are maybe having 1 or 2 symptoms, will not be full array. But 50 is age that we consider BPH as their diagnosis, because before that, people are thinking about other things when they present with their lower urinary symptoms.
Thank you very much, Dr. Kanchana Edirisinghe, for that wonderful lecture. Now you know whether you have symptoms of prostatism. So if you have, you know what to do. And yet another question actually got to the message. Does it affect to the activity of the sexual activity at the starting age of the sex in the male? Starting also, there are people who start sexual activity in the early stages, and some also. Whether there's a relationship with that.
They were talking about that, but I really don't know the real answer or the actual answer.
So thank you very much, Dr. Kanchana Edirisinghe. So may I cordially invite Dr. Uday Kalubowila to hand over certificate of appreciation to Dr. Kanchana Edirisinghe. Thank you very much, sir. Thank you very much. So thank you very much all the physical participants and also the online participants. So your refreshment will be available on the other side of the room. Thank you very much.